Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
This program is presented by Medscape Education Global.
Hello, everyone. I'm Alice Chang, endocrinologist at the University of Toronto in Canada, and welcome to this program entitled Advances in the Pharmacologic Management of Obesity, an Expert Digest of the Latest Data. Joining me today is Professor Arya Sharma, Professor Emeritus of Medicine, University of Alberta in Edmonton, Canada, and internationally recognized expert in obesity medicine. Welcome, Arya. Well, we're coming towards the end of the year, and we have just had the EASD and lots of exciting data presented there. Let's review the latest updates on obesity management. And Arya, to get us started, could you tell us a bit about a couple of recent consensus statements and guidelines for managing obesity, specifically from the European Association for the Study of Obesity, as well as the hot off the press Canadian guidelines from August of this year?
Well, Alice, with all of the exciting stuff that's going on in obesity, there's a lot of excitement about actually defining treatment pathways and ultimately also deciding what the best options for treatment are. And this starts with the diagnosis of obesity. We all know that body mass index is not really a precise measure of health. It's a measure of size. And so we've seen in the European Association for the Study of Obesity just publishing new guidelines and recommendations where they say that it's basically a clinical diagnosis. So we have the BMI, we have anthropometric components that we have to look at, like waist circumference, etc. But we also have to remember that there's a clinical component to assessing someone for obesity, where you're very specifically looking for, are there any functional impairments? Are there any, psychological impairments? Or are there any metabolic impairments that would, suggest that this person really needs obesity treatment? And so, it's something that we have to get used to, that this is not a number on the scale or a number on a chart that helps define obesity. We really have to basically look at our patient. And that involves the assessment. Now, when it comes to the initiation of pharmacotherapy, I think we can all agree that with the recent advances in the pharmacotherapy of obesity, that is now probably going to be the choice that most patients eventually are going to make if they have access, of course. And so the guidelines also makes quite specific recommendations for different comorbidities. Let's put it that way. So what you can see, for example, is based on the results of some of the studies. Takes the SELECT trial, for example, where we've shown that semaglutide, for example, reduces cardiovascular risk in people who have high cardiovascular risk. That, of course, would be a first-line medication for someone who has obesity and is in that category. And of course, we have recommendations for other comorbidities, all depending on what the published data is. Now, at the same time, virtually, in fact, just a couple of weeks before, we had an update to the pharmacotherapy chapter in the Canadian guidelines. And here again, the recommendations are very specific for very specific comorbidities. So, for example, looking at the data, depending on whether your patient's primary complaint is sleep apnea or whether it's cardiovascular disease, or whether it's HFpEF. For all of these outcomes, we now have studies with individual agents, and so there are specific recommendations for these agents.
And it's quite exciting that we can even create tables like this now, to be able to show all the different kinds of data and outcomes that could potentially be reduced. So with this in mind then, Arya, and knowing that pharmacotherapy is obviously a very important tool in our toolkit for helping people living with obesity, let's take a look at some of the data. I'm going to start with some of the updates that we saw at EASD, knowing full well that we cannot possibly cover everything. So we are going to pick and choose some of the standout presentations. And to get us started, I'm going to speak specifically about two of our more established medications used in chronic weight management, specifically semaglutide as well as tirzepatide. So, in the semaglutide space, we saw some additional data from the STEP UP study. And just to remind everyone, the STEP UP study is one of higher dose semaglutide, 7.2 milligrams subcutaneous, compared to that of 2.4 milligrams subcutaneous versus that of placebo in individuals living with obesity. And we already saw previously the data from STEP UP demonstrating that the 7.2 milligrams does in fact further reduce weight beyond that of the 2.4 milligram, with more individuals achieving body weight loss categories of 20% plus or even 25% plus with the 7.2 milligram dose. But at the EASD, we saw some additional data looking at anthropometric measures of obesity, knowing full well what we just heard from Aria, that although these are important measurements, these do not fully reflect necessarily the comorbidities of the individual. So we always need to include that clinical context. But to give you a bit more of the changes in the anthropometric measures, so starting with proportion of participants achieving different BMI thresholds, there were a lot more people achieving BMI thresholds below 25. So 15.6% from the semaglutide 7.2 compared to 7.9% at 2.4 milligrams. More people achieving under 27 and a lot more people achieving under 30 kilograms per meter squared. And then therefore, the distribution of BMI classes from baseline to week 72 obviously changed, with a larger proportion of individuals on 7.2 milligram actually achieving BMI thresholds that are defined as either overweight or quote unquote normal weight. And then waist to height ratio, waist circumference, similar data demonstrating that the 7.2 milligram dose does it affect these more so than the 2.4 milligram dose. And then, very importantly, there's always the question of okay, if there's greater weight loss, then what does that mean in terms of functionality? So, here, this is an MRI subpopulation, 49 people in the pooled SEMA group versus 6 people in the placebo group. So, really, just a taste of the potential effect. And looking at sit to stand repetitions, and it's reassuring to see that there was no decline in sit to stand repetitions over time. And in fact, numerically, it was 13 at baseline compared to 15 at week 72. So good and very similar to that of placebo. So we're not negatively impacting function. And then when looking at different tissue volumes, greater loss from an adipose tissue volume at total as well as visceral, but also as expected, greater loss of muscle mass, but not sort of disproportionately so compared to what we're used to from other forms of weight loss. So additional data from Step Up generally showing improved anthropometric measures with the higher dose of semaglutide. And then very excitingly at EASD was a early morning session looking at the results of Surpass CVOT. So Surpass CVOT has long been awaited. It is the cardiovascular outcome trial of tirzepatide with an active comparator of a GLP-1 monoagonist dulaglutide, which already has established cardiovascular protective data in type 2 diabetes. So this is tirzepatide versus dulaglutide on cardiovascular outcomes in those living with type 2 diabetes and atherosclerotic cardiovascular disease. Now, before I get into the actual MACE data or cardiovascular data, given that we're speaking about obesity, let me give you some of the interesting metabolic data in this head-to-head study of tirzepatide versus dulaglutide. Over the 54 months of the study, it was interesting to see the body weight difference between tirzepatide compared to that of dulaglutide, with a percent change from baseline difference of 7% between tirzepatide and dula, with tirzepatide being greater. And then also from an A1C perspective, also demonstrating greater A1C reduction with a difference of 0.8% with tirzepatide compared to that of dulaglutide. But that, of course, was not the main purpose of Surpass CVOT. The main purpose was to look at it from a cardiovascular perspective, and non-inferiority was demonstrated, meaning that tirzepatide is as effective as dulaglutide in secondary prevention type 2 diabetes patients for cardiovascular outcomes of CV death non-fatal MI, or non-fatal stroke. And remember, establishing already that dulaglutide is cardioprotective. So therefore, clinically, I would interpret this as now tirzepatide also has cardioprotection data in type 2 diabetes with established atherosclerotic disease. Now, obviously, we saw data breaking down the different components of MACE and the different components of the cardiovascular outcomes. And what was interesting to observe, although conclusions cannot be drawn given that the primary outcome was non inferiority, but interesting to observe a reduction in all cause death in the tirzepatide group compared to that of the dulaglutide group. So, all in all, I think good news for people living with diabetes and cardiovascular disease, showing that tirzepatide offers cardiovascular protection as well. Now, those are a couple of the data. There were some other updates as well at EASD, particularly on oral medication and some interesting new combinations. So, Aria, over to you. Can you let us know about some of those?
Yeah, there was certainly a lot of excitement about all of the new medications that are out there in the pipelines. There was quite a bit of excitement also about new data from the REDEFINE study, which was a trial of cagrisema, which is a fixed combination of cagrilintide, which is an amylin agonist, and semaglutide in people who were living with obesity who did not have diabetes. And there was quite impressive weight loss in here. And I think one of the medications that everybody's kind of excited about is orforglipron, which is a small molecule GLP-1 receptor agonist. So this is a molecule which I think could be a game changer in the sense that this is a small molecule. It binds to the GLP-1 receptor, and this was studied in the ATTAIN-1 trial, looking at its effects on weight loss and other metabolic parameters. And in fact, it seems to be just as effective as the subcutaneous sort of application. So as what we saw in ATTAIN-1 was that there was fairly good dose response relationship here in terms of weight loss. Maximum weight loss here at the highest dose was around 11%, which is which is pretty good. So we're in the same ballpark as you are with the subcutaneous GLP-1 analogs. When we look at all of the other parameters that changed, in terms of response, we're seeing a similar pattern of response here. When we look at the number of people who've lost 10%, 20% weight loss, it's very, very comparable to what you would expect from this from GLP-1 receptor agonists. Similarly, when you look at changes in waist circumference, etc., we're in the same ballpark. So I think this is going to be certainly a treatment option for people who would much rather be taking an oral medication. One of the interesting things I saw in ATTAIN-1 was that there was quite a remarkable reduction in blood pressure. In fact, as being someone who has quite a bit of interest in blood pressure myself, this having been one of my research areas before I got into obesity, we actually see that systolic blood pressure, diastolic blood pressure is significantly reduced. And I think this is obviously important because we are looking at GLP-1 receptor agonists as a treatment for people who are at high risk of cardiovascular disease. In terms of tolerability, there was really no surprises here. This is the usual GI side effects that by now I guess most of us are used to seeing in our patients on GLP-1 analogs, and so I think this is something that we can certainly look forward to. Now, in terms of other molecules, unfortunately, we won't have the time to go through all of them. There was a lot of other interesting molecules. Just to mention one is amycretin. This is an oral molecule that binds to both the amylin receptor and the GLP-1 receptor, and that's going to be very interesting because amylin is going to be a new mode of action, one that we haven't actually really explored or seen much of in the context of obesity. There's a whole bunch of other molecules that are in pipelines. In fact, when we look at the number of molecules that are in the pipeline, it's almost overwhelming what we have now in phase 1 and phase 2, and starting to move into phase 3 studies. So this is definitely a very exciting space to work in. I pity the poor guys who are going to have to be writing the guidelines in a couple of years from now with all of these choices, and the clinician who's going to have to, decide which ones to use in which patient. But obviously, from a science perspective, this is extremely exciting. And I think we're going to, we're just entering this era of being able to offer our patients who've been struggling with obesity for so many years, new treatment options. And I think this is going to make a real difference in our management, not just of obesity, but obesity and all of the relevant comorbidities.
Yeah, I couldn't agree more, Arya, and thank you for that summary. It's an exciting space. I want to pick up on that. One of the things you said though is that the challenge is going to be not just for guidelines writers, but I think as clinicians to figure out what to use. In that we're going to have so many different choices, and I think that personalized medicine and really figuring out the right fit for the right person is going to be sort of that next frontier that we are going to need to figure out. So, in the meantime, Arya, I want to thank you for this great discussion. And I want to thank our audience for participating in this activity. And please continue on to answer the questions that follow and complete the evaluation. Thank you very much, everyone.
This program was presented by Medscape Education Global.